This is a web-based instruction for nurses and doctors in urological care. Doctors for Africa and other organizations provide urological care in African hospitals. Also see previous presentations on lower urinary tract symptoms for the ward postoperative care. The purpose of this lecture is understanding and coping with urological complications. Local staff should be able to take care of postoperative complications. By knowing the possible complications, you can also try to prevent them better. About the content of this talk, listing of tips and tricks, bladder washout in clot retention, reinserting irrigation catheter after TURP or open prostatectomy, insertion of catheter in difficult cases. Clot retention in primary gross hematuria. So the patient presents with hematuria and is unable to pass urine. First, insert a catheter with a firm consistency to be able to put vacuum on the catheter, to be able to put vacuum with the catheter syringe. A floppy latex catheter will collapse. First, introduce about 50 ml of normal saline. Pull the bladder syringe to remove the clots. Prevent suction of the bladder wall, which is painful, so look the patient in the eyes. Insert the catheter at different depths to find new clots. Start manual irrigation by inserting 50 to 100 ml of normal saline and irrigate until the syringe has filled with clots and empty the syringe and restart. Continue until the irrigation fluid is completely clear. Then insert a three-way irrigation catheter with continuous flow. Clot retention after TURP or open prostatectomy. The symptom is that the irrigation fluid stops running and the urine becomes bloody. First, check the system. Is the irrigation bag not empty? Are the tubes not kinked? Is the catheter not kinked? Irrigation tube on the smaller opening of the three-way catheter. Opnieuw. The irrigation fluid should be connected to the smaller opening in the three-way catheter. Kink the catheter and squeeze the catheter between the kinking and the penis, and then opnieuw. Kink the catheter and squeeze it between the kink and the penis, like you milk a cow or goat. This might mobilize the clots. Remove the urine bag and start manual irrigation as in primary clot retention. Apply traction to the catheter to block the prostatic cavity. If this helps, you can apply continuous traction for a maximum of 4 hours, then release it and you can restart the traction after about half an hour. This is to prevent necrosis of the bladder neck. Read the postoperative notes. Is the balloon in the catheter? Read the postoperative notes. Is the balloon in the bladder? Then consider to take some fluid from the balloon, retract it carefully until the balloon is in the prostatic cavity, and then fill the balloon again for direct pressure on the prostatic capsule. Call for a urological supervision. If there is no urological supervision available, then give rectal compression on the prostate by inserting a finger in the rectum and give pressure on the prostate. You should continue this for at least, you should continue this pressure for at least 10 minutes. If bleeding persists and blood transfusion is needed, patient has to return to theater for patient needs to if bleeding persists and blood transfusion is needed, return to theater for transurethral inspection and coagulation, also in patients after open procedures. Do not give any tranexamic acid. This will cause very dense clots that will not be able to be rinsed out of the bladder. The last resort after open prostatectomy. Open the wound and pack it with gauzes and remove the catheter and remove the gauzes after a couple of days. Reinserting an irrigation catheter after TURP or open prostatectomy. In case the irrigation catheter has come out or there is inability to void after catheter removal, catheter should be reinserted, preferably a 3-way catheter. If that is not successful, use extra lubricant or insert an index finger in the rectum of the patient and give the catheter an upward lift. This is a very magic trick. The problem is that the tip of the catheter might get caught in the prostatic capsula and does not enter the bladder through the bladder neck. You could also use a catheter stillet, but often this is not available, and due to the rigidity of this stillet, it might be a risk in getting a perforation of the prostatic capsule. Safely is to use a guide wire. Insert this through the urethra into the bladder, make a small opening in the tip of the catheter and pass the catheter over the guide wire into the bladder. Last resort, do a flexible cystoscopy and introduce a guide wire. Difficulty in catheterization. If a urethral stricture is considered, stop trying to introduce a catheter, but give the patient a suprapubic catheter. Use extra lubricant. Keep some pressure on the catheter and try to get the patient relaxed. When he relaxes the pelvic floor, you then can proceed the catheter into the bladder. You can again use a catheter stillet. Use a guide wire to get in the bladder and then insert a catheter over the guide wire by making a small opening in the tip of the catheter. Beware of Timan tip catheters, because if you do not get out of the tip of the catheter, then you have some kind of a hook which will prevent you from getting the catheter in the bladder. So if you use a guide wire, the opening should be exactly at the tip of the catheter. After urethroplasties, the catheter is imminent for 1 to 4 weeks, depending on the type of procedure and the advices of the surgeon. Before removing the catheter, a micturition cystography is done to exclude leakage of the plasty. You can do that with a pericatheter. You can do this with a pericatheter micturition cystography by filling the bladder with radiographic contrast and then have the patient void with the catheter still in. You can make an X-ray to see if there is any extravasation. The problem might be that this causes higher pressure and induces non-physiological extravasation. You can also do a free flow. Fill the bladder with contrast, then remove it and have the patient void under X-ray guidance, or just take an X-ray at the moment of peeing or just after it. If there is extravasation, the catheter should be replaced for at least 7 to 10 days. Reinsertion of the catheter often is not a big problem because there has been a catheter for some weeks. In case of wound infections and fistulations after open prostatectomy, remove the distal sutures and open the wound. If necessary, also open the distal fascia. This can also be done if running sutures are used. In case of urine leakage, you can only wait for spontaneous closure. Keep the transurethral catheter in and drape the wound. Keep the transurethral catheter in. In due time, the problem will resolve. After urethroplasty, the wound infection would be perineal. Open the wound as you should with all postoperative wound infections. Keep the catheter in place to prevent formation of fistula. In case of fistula and lack of spontaneous closure, repair should be done after the scar tissue formation has stopped. Wound care in general. Many hospitals have their own routines. It is not up to us to change these routines without any motivation. In general, we are used to reduce the amount of gauzes and plasters because most wounds are wet, and if you dress it, the moist dressings is a nice warm environment for bacteria to grow. In open abscesses, this is the case too, so apply gauze dressings and redress at least twice daily. In the West, water from a shower into the open wound is advised, at least twice daily. There are also special dressings that do not adhere to the wound but absorb the fluids. In general, after in general, when the team has left for their home countries, they will have left their WhatsApp contacts. Feel free to get in contact with the team to discuss any problems and ask for advice. Thank you all for your cooperation. Together, we try to do the best for our patients.